Welcome to SheTV.com, where board-certified physicians talk to you about women's health. In this episode, Dr. Sarah Mashburn, a practicing OB-GYN, talks to us about the choice between being induced versus waiting to go into labor spontaneously.
Good evening. I am Dr. Dana Bach. I am a board-certified anesthesiologist. I practice at Lakeside Women's Hospital in Oklahoma City, Oklahoma. This evening, I am visiting with Dr. Sarah Mashburn. She is an OB-GYN. She also practices at Lakeside Women's Hospital. She is one of our new young doctors. We love to have young faces in the building. I used to be a young doctor in the building, and that was about 20 years ago. So we're very happy to have you there working with us on a daily basis. We wanted to talk today, or I want you to talk and maybe come up with some of the frequently asked questions you have about patients that are ready to have babies, they're term or close to term. Should they come in spontaneous labor and wait for that to happen, or can they be induced? And why don't you take it away? I think you'll be able to answer anything that we might want to know.
Yeah. So, first, thank you for having me. Excited to be here. I think this is one of the most common discussions that I have in the office with patients, because, a lot of patients are lucky enough to have pregnancies that are not complicated by, chronic or new pregnancy medical conditions. And so they rightfully want to know, like, what's the best way to have my baby? And I think the shorter answer is that depends. And it depends on a lot of things. It depends on your goals. It depends on, your pregnancy and how things have gone thus far. But I'm going to try to kind of highlight some of the things that go into that discussion that I have with patients. And this is not including people who have, medical reasons that we would recommend inducing labor. So that would be like high blood pressure, whether it's throughout pregnancy or that develops in pregnancy, poorly controlled gestational diabetes, any concerns about baby, etc. So this is just, your healthy, uncomplicated pregnancy. This patient comes in at, 35, 36 weeks. They're starting to get a little bit uncomfortable, starting to get harder to walk around, harder to sleep. And they say, what should I do? How am I going to have my baby? So what we're talking about is elective induction of labor, meaning it's not medically indicated. It's just a choice. So elective induction of labor can be offered starting at 39 weeks. So we don't induce any earlier. We want fully developed, grown term babies.
Okay.
An elective induction of labor can be offered really at any time 39 weeks or beyond if you're not already in labor on your own. So some of the benefits to inducing labor is, obviously the planning aspect of it. So for patients that they don't know when their significant other is going to be able to take off of work, or they want to make sure that their doctor that they've seen the whole pregnancy is the one that delivers their baby, or they have family that's traveling in out of town that's going to only be able to take 2 weeks off and they want to come be able to help with the baby. These are all very valid reasons to try to kind of plan when you're going to have your baby. The other thing that we talk about a lot is that there was a really large study followed by several smaller studies that set out to look at, okay, what's better, awaiting spontaneous labor or maybe induction at 39 weeks. And the main thing that they set out to see was, okay, is this going to result in better baby outcomes? Like, are we going to have less of those really bad outcomes that we see late in pregnancy? And they actually didn't see that, because those really bad outcomes like stillbirth are so rare that they didn't see a difference in those things. Okay. But they did have a really surprising finding of their study is, and it's actually the opposite from what a lot of people assume about induction of labor, is that induction of labor at 39 weeks actually decreased their C-section rates, as opposed to waiting for labor. And so this kind of makes you wonder, why would this happen? And so we think that probably for a couple of reasons. So babies gain on average 0.5 pound a week towards the end of pregnancy. So a baby at 39 weeks may weigh about 7 pounds, whereas a baby at 41 weeks may weigh 9 pounds. And for some women, that's the difference in whether or not a baby can fit through their pelvis. So we think maybe slightly smaller babies. The other thing is we think the placenta that's supplying all of the oxygen and nutrients to baby probably functions at its peak around 39 to 40 weeks. So you may come in and at 41 weeks in active labor and, we're not in a absolute emergency, but baby may just not tolerate labor long enough for us to wait for that vaginal delivery. And so those are kind of the thoughts behind why this might work and why this might have this benefit. That comes with a big asterisk, actually two of them, two big ifs. And that's if your hospital or facility can accommodate elective inductions of labor. So we know that safe nursing staffing, safe physician staffing, all of these things are essential. And if the hospital cannot accommodate, having people maybe spend more time in labor and, have those safe staffing ratios, then it may not be a great idea and may not be something that's offered at your hospital. The other big if is, these decreased C-section rates really only occur if we're following the guidelines for when we're going to call a C-section, which means that we as OB-GYNs and as patients too have to be really patient with induction of labor. It takes time, and that's probably getting into some of the cons of elective inductions of labor. They take a little bit longer sometimes. So I tell patients, it is not uncommon to, from the time you walk through the hospital doors to the time when you have your baby, for it to be 24, sometimes 36 hours before you're holding that baby in your arms. And that's okay. So I talk to people about those risks as well.
That's good. That most patients want to walk in the door and have a baby in 30 minutes.
Yes.
And that's just not how it normally happens.
Correct. These things take some time. Because essentially with induction of labor, we're kind of mimicking all of those early labor things that happen typically at home for the, 12 to 24 hours before you come into the hospital. The other thing that I always talk to patients about with induction of labor is whether or not it's very important to them to avoid or obtain an epidural. Because for some patients, they really, really do not want an epidural. They would prefer to, labor naturally, and that's something that's very important to them, and that's great. It is not a requirement to have an epidural when you're getting induced, but we do know that patients are typically more likely to get epidurals and inductions than they are in spontaneous labor. And that's just due to those contractions that we cause with the Pitocin can be pretty painful for some people. And so people tend to be more likely to choose neuraxial anesthesia whenever they're being induced. But it's definitely not a requirement. And there are people who have unmedicated natural birth while they're being induced.
What do you do with an induction? If someone comes in and they're a scheduled elective induction, what happens?
So it kind of depends on where we're starting. So it depends on how dilated the cervix is, how soft the cervix is, if it's thinned out. So for some patients, they come in and they're already like 2 to 3 centimeters dilated. So they may not need the cervical ripening aspect of a scheduled induction. So typically in those scenarios, we would just start with Pitocin, which is a medication that goes through the IV that causes those regular contractions. And it is not an all or nothing medication. We start really low and we increase little by little based off of how your body is contracting, how you're tolerating it, how your baby's tolerating it, all of those things. And then at some point, a lot of times we end up offering to break your water because that can make the Pitocin work a little bit more effectively. For some patients, their cervix is not dilated, or maybe it's dilated a little bit, but it's not really thinned out yet. And so those patients, we typically offer and recommend something called cervical ripening, which can consist of, they make little pills that can be placed in the vagina that can called misoprostol or Cytotec that can soften or thin out the cervix. They make a similar medication that looks like it's on, it almost looks like a little flat tampon, but it's on a little string that you place up inside the vagina. They make gels that are still used in some facilities. Also, they make the little balloons that can go inside the cervix that we place through the cervix when you're about a centimeter dilated. They have a balloon that we fill with saline that goes on the top of the cervix. And then that puts pressure on the cervix like baby's head. And typically when that cervix is dilated enough for the balloon to come out, you're 3 to 4 centimeters dilated. And then we just pick up with the Pitocin just like the people who started out at 3 centimeters dilated or so.
Okay. Okay. How safe is all of this? Is there a difference? I know we talked about C-section rate. Is there any difference in safety for babies?
So when we look at the outcomes, so when we look at the final, are we sending more babies to the NICU? Are we having more babies being born in the setting of infection? Are they more likely to have meconium? There are really no differences between induction and spontaneous labor. In fact, we know that babies that are born closer to 40, 41, especially 42 weeks, are actually a little bit more likely to have meconium at delivery and may need a little bit of respiratory assistance if they try to inhale some of that pool water at delivery. In terms of, sometimes into small short-term things that we worry about with inductions, we worry about you contracting too much. So sometimes when we're giving you medication, the uterus responds really well to that, and those contractions are occurring more frequently than we want them to. So in those settings, typically what we do is if we're giving you something to contract like Pitocin, we take it away. We turn it off. We turn it down. We give you fluids through your IV. And those type of things can typically slow down or stop the contractions. And we also have if those things don't work, we have a medication that we can give in the form of an injection that does slow down and stop the contractions. But that is one thing that we sometimes, one of the reasons that we, monitor people in the hospital, we're not doing inductions at home, is we want to be able to monitor the frequency of contractions and slow those down if we need to.
Okay. What if I come in as a patient and I'm a scheduled induction of labor and nothing happens? Does that ever happen? Does the cervix
Sometimes
never
it does.
not respond? Am I just going to be
Yes.
pregnant the rest of my life, or what? What do you do?
So in the setting of an elective induction, as long as your baby looks great on the monitor, so we're seeing that the heart rate is still showing signs that there are no issues on the inside, and your blood pressures are still normal, you can leave the hospital if an induction is not working well. The turning point at that is once your water is broken, we recommend staying in the hospital. But prior to your water being broken, if we've given you, several doses of that misoprostol or that Cytotec and the cervix is just not budging and you don't want to continue on, that's totally fine. We usually give you some fluids, watch your baby for a little bit without the medication on board, and then let you go home. And you can either wait until you labor on your own, or sometimes we have people that they come back, a week later and try again.
And I would guess that next time they try, maybe it's a more favorable outcome.
Yeah. So I've seen that happen before that, we try and the cervix just doesn't want to soften or dilate for us. And then we try again a week later and it goes like that.
Okay. Which is what we all want.
Yes.
We all want
exactly.
a healthy mom and a healthy baby.
Yes.
All right.
That's the goal at the end of this.
Yeah. Anything else we didn't discuss, or that I didn't think to ask a question about?
The thing is, we talked a lot about the elective induction. We didn't talk as much about the spontaneous labor, but I think it's important to ask your doctor, like, am I low risk? Like, what's the risk of me waiting to have my baby? And if you're healthy and your blood pressure's good, and you decide that you'd rather have that early labor stage at home, or that you don't want to get Pitocin unless you need it, or things like that, awaiting spontaneous labor is just fine too. I think a lot of times we end up talking a little bit more about elective induction of labor just because there's probably more misconceptions about that. People kind of know more about going into labor on their own. So naturally we talk about the one that people don't talk about as much. But your doctor should be giving you all the options, all the pros and cons, and kind of individualizing those to your scenario. And the right and wrong decision just depends on the person and the scenario. And sometimes there isn't even a right and wrong decision. It's just what sounds good to you. And that both of those options are great. And I just think that's why it's so important to have a doctor that you trust and that you can talk through these things with and ask those questions to figure out which is going to be the best option for you.
Okay, that sounds perfect. All right. Well, I want to thank you so much for joining me this evening and talking with me about this topic. And I'm sure we'll be getting back together with some other things to discuss in the future.
Yes, absolutely. Thanks for having me.
You bet. Thanks. Bye-bye, Dr. Mashburn.
Bye-bye.
Thank you for watching SheTV.com, where board-certified physicians talk to you about women's health.